My name is Angela Taylor. I'm the Director of Programs at the Lewy Body Dementia Association. I am very pleased to be here to share with you some information about Lewy Body Dementia. We have a mix of people registered for today's event, so I will provide some basics that will be a repeat for some of you, and for others it may be brand new, so bear with me if some of this is information you're already familiar with. So we're going to cover a general overview about LBD. I'll compare and contrast it to Alzheimer's disease and Parkinson's disease. We'll talk about why in LBD specifically a diagnosis is very important, a differential diagnosis, and what's involved in comprehensive treatment and why that is critical. I'll review some of the common challenges that families experience, such as seeking a diagnosis and the challenges of low public awareness. And then I'll provide an overview of some of the resources that are available to families today. So to make sure we're all on the same page, I just want to talk a little bit about what dementia is. It is not a disease in itself. It is basically a syndrome or a collection of symptoms that basically means that you have enough cognitive decline that it interferes with your ability to take care of your everyday life. And it affects a number of different skills, such as memory, language, problem solving or executive function, your judgment, attention, and your visual spatial skills, such as how you understand how things are oriented in three-dimensional space. It can also affect a person's behavior. What's most common is that many people assume that when you're talking about dementia, you're talking about Alzheimer's disease. But there's actually many causes of dementia, some of which can be treated and others which are progressive and irreversible. So let's talk a little bit about those. So there are some medical conditions like thyroid disease that can be diagnosed and treated, and the person resumes to their baseline cognitive skill. Older people often will have changes in their cognition because of medical drug reactions. And then there are physical things and changes that will happen, like a brain tumor can affect somebody's cognition. But for today's webinar, what we're really going to be talking about are the progressive dementias, and obviously today primarily focusing on Lewy body dementia. But there are other forms. Everybody's familiar with Alzheimer's disease, and most people are aware that stroke and other vascular problems can cause dementia as well. And then there are forms of dementia that are not as common, like frontotemporal dementia. Lewy body dementia is a progressive disorder, as I mentioned, and it's named after the doctor who first identified these protein deposits in the brain at autopsy, and his name was Friedrich Lewy, and he was a neurologist who worked at the turn of the century. And he was doing an autopsy on the brain of a person who had Parkinson's disease, and over time, these little deposits were named after him. So when we talk about Lewy bodies, we're talking about this molecular or cellular change. LBD is not very well known, but it is not at all a rare disease. In fact, it's the second most common form of dementia after Alzheimer's disease. And we estimate that it affects about 1.4 million Americans, plus all of their family members, as you can imagine. It's slightly more common in men than it is in women, and like Alzheimer's disease, it's a disorder that affects older adults primarily. Most people are diagnosed with LBD. They're older, over the age of 50. However, we are seeing some people diagnosed earlier than that. So the term Lewy body dementia is an umbrella term, and it encompasses two clinical diagnoses. One is Parkinson's disease dementia. And that diagnosis is used to identify somebody who has had a standing case diagnosis of Parkinson's disease, and over time, their cognitive skills have declined. By the time it's progressed enough that it affects their independence, then it's defined as Parkinson's disease dementia. But that generally happens several years or more after they're diagnosed. For a person who presents with dementia, and has some of these other symptoms of LBD, they may walk and talk quite a bit like somebody who has Parkinson's disease dementia, but the order in which their symptoms present are different. So they may have some Parkinsonism at the beginning, but over time, rather primarily their presenting symptom is generally the dementia, as when we look at the order in which it occurs with the Parkinsonism. But the Parkinsonism may occur within that first year as well. So when we talk about the causes of LBD, we're still trying to really get to the bottom of that. We don't know why these proteins are misfolding in the first place, and we don't know yet how much genetics play a role in this. Right now, most cases of LBD are considered spontaneous. They don't have a known genetic cause. So it may be a combination of genetic and environmental factors, as well as things that occur in the natural aging process. I'm going to go through the symptoms of LBD next, and we're going to focus on them in sections. We'll start with cognition. People with LBD may experience some forgetfulness. They may have some memory impairment, but it's typically not as significant as what you see in early Alzheimer's disease. More often, it's actually a loss of attention, but it may look like memory if you're not familiar with what to look for. They will have significant changes in their ability to problem solve or understand abstract or analytical concepts. So anything that requires doing things in sequence or keeping track of multiple pieces of information in their minds at the same time, very difficult. Planning becomes more difficult. And speech becomes disorganized. There's word substitutions, there's jumbled speech. It can be difficult over time for them to articulate themselves. And as I mentioned, visual spatial skills, or a person's sense of direction or understanding how objects relate in space, they get significantly impaired. Their cognitive and attention skills become really unpredictable, and so we call that fluctuations. So a person's ability to perform a task from day to day or even hour to hour may not be the same. It may vary unpredictably. They will also have episodes of confusion or may present with some delirium-like symptoms. And one of the ways that researchers have been able to try to objectively measure this is to look at whether or not they have excessive daytime sleepiness. Is their attention reduced, and are they falling asleep very easily during the day despite having enough sleep at night? People with LBD will likely develop some signs of Parkinsonism or symptoms resembling Parkinson's over the course of their disorder. Often it's muscle stiffness or rigidity. They don't move fluidly. Their gait or walk will change so that their steps are more shuffling. Repeat falls are very common and is one of the warning signs that you may be dealing with something that's in the Lewy body realm. Balance is affected. And they may have a tremor, but it's likely a little less pronounced than what you might see in Parkinson's disease. Certainly their movements slow considerably, and they will have a slack facial expression and a change in posture. So it's understandable how it's possible to misdiagnose this if you're looking and seeing a lot of motor symptoms around the time somebody is also presenting with dementia. Very common in LBD are for people to have visual hallucinations, and this is one of the early differentiating signs of the disease. People with Alzheimer's disease may have it later, but in LBD, they're often small people like children, animals, insects. Sometimes they are not concerning or upsetting at all, but sometimes they are. So it's important to identify if somebody's having behavioral changes, maybe what's the root of them. Delusions are very common. A delusion is a false, fixed belief about something that doesn't have a base in reality. And while they have these psychotic symptoms like hallucinations, they happen to be exquisitely sensitive to medications that are typically used to treat hallucinations. And so we have to have a very careful balancing act there. But somebody with Alzheimer's disease doesn't react that way to some of these medications. And so if they're responding poorly to a treatment for hallucinations, it's another warning sign that this may be LBD. Certainly, Changes in mood are very common: depression, apathy, anxiety. This is, in part, the depression is biological because of the loss of dopamine, but it's also, obviously, as you can imagine, situational as well. Sleep disorders are very common in LBD, and one of our scientific advisors says, who is a sleep expert, says he's very hard-pressed to find somebody who doesn't have sleep disorders when they have LBD. Most common is a disorder called REM sleep behavior disorder, or RBD. And this is in which a person physically moves about while they're having dreams, where most of us, when we dream, our bodies are essentially immobilized. But if a person's having a frightening dream, they're going to kick and shout and punch, and often they will injure themselves or their bed partner. So this particular symptom can predate the onset of dementia, not just by months, but years and even decades. So this is a known risk factor for Lewy body dementia and other related disorders like Parkinson's disease and multiple system atrophy. Insomnia is very problematic for some people. And, other symptoms like restless leg syndrome, sleep apnea, they're also something that need to be assessed for in LBD. So, beyond motor symptoms, behavioral symptoms, cognitive symptoms, we also see a change in a person's autonomic nervous system. And this is the nervous system that regulates the automated functions in the body, like blood pressure regulation, temperature regulation, et cetera. So people with LBD may experience something called orthostatic hypotension, where they may stand up and should have an according rise in their blood pressure in order to ensure the brain gets enough oxygen. But their blood pressure doesn't raise, and so what they may experience is lightheadedness or even fainting. So blood pressure regulation should be monitored. Temperature regulation, cold sweats, temperature insensitivity to hot or cold is not unusual. Urinary incontinence can happen early in LBD. This is something that obviously is a dignity issue, but it's very common for us to see this early. Chronic constipation is a known symptom of both LBD and Parkinson's disease. It is something that needs to be proactively managed throughout the disease course. And also we see episodes of unresponsiveness or people not being able to be woken up and whatnot. These also are difficult for families to understand and manage, and sometimes, will result in a trip to the because it makes them very concerned as to what's going on, obviously. But it is actually part of the disease process. So that's the overview of the symptoms of LBD, but what I want to talk about is now how does that compare? We're certainly, when we look at Alzheimer's disease, the symptom that everybody thinks of most often is memory problems. But as I articulated, memory is relatively spared in the early stage of LBD. And people who don't know the individual who's in early stage LBD may not know in a normal social conversation that there is anything wrong with them, because they won't be doing some of the more complex cognitive tasks if they're just having a social conversation, and so that nothing may resonate to somebody who doesn't know them as unusual. These disorders have different biological bases as well. The two proteins implicated in Alzheimer's disease are amyloid and tau. But in Lewy body dementia, the protein that's misfolding is called alpha-synuclein. So not only do the symptoms vary, but what's going on in the brain at a biological level itself. And so what may be really helpful when we're talking about differential diagnosis is to look especially for two symptoms, and that's REM sleep behavior disorder, and that's the one where people are physically acting out their dreams, or the presence of visual hallucinations early in the dementia. These two things are highly suggestive of LBD over Alzheimer's disease. So let's do the same thing now, except we'll talk about Parkinson's disease. As you see here, both Parkinson's disease and Lewy body dementia are associated with the same protein misfolding, alpha-synuclein. and so they are biologically related. But what's different is the area in which the Lewy bodies are seen early in the disease. So in Parkinson's disease, they're largely seen in the substantia nigra, and that's associated with all of the movement changes that you experience. But in somebody with Lewy body dementia, they're seen in the cortex and other areas of the brain, but primarily the outer layers of the brain. They also may be in the substantia nigra, which explains why they may have Parkinsonism. But if you were to look at these two patients in these two conditions, early stage disease at autopsy, the presence of the Lewy bodies are in different places. So this then goes along with what primary symptom is always involved. So a person who has Parkinson's disease always has changes in movement at the beginning of the disorder when it's being diagnosed. And a person who has Lewy body dementia always has significant cognitive symptoms. Now, Parkinson's disease may have some mild changes in cognition at the time of diagnosis, and over time that may get much worse. But it's not we separate the diagnoses by when that cognitive decline reaches the stage of dementia in comparison to when the motor symptoms begin. So there's an rather arbitrary one-year line that researchers use to study these two patient populations apart, and that's 1 year. If the cognitive symptoms, if dementia presents first or within a year of the Parkinsonism, then that's diagnosed as dementia with Lewy bodies. If the Parkinsonism comes first and dementia does not occur for at least a year or more, then that, as I said, is diagnosed as Parkinson's disease dementia. But as you can see here, these are very closely related diseases, and we have a lot of work to do to understand why some people develop primarily Parkinson's disease or why other people develop Lewy body dementia. So from the context of getting a differential diagnosis, when we talk about LBD, we feel it is absolutely essential to get that diagnosis as early as possible. And one of the reasons is that people with LBD actually tend to respond better to the cholinesterase inhibitor medications. And these are medications developed originally for Alzheimer's disease. So medications like Aricept and Exelon fall in that class. Those medications may also help with the hallucinations. And so there's a really good reason to get an accurate diagnosis and get those treatments on board early. We also have come to learn that looking across all of the symptoms of LBD and treating them all really improves not just the quality of life for the person living with the disease, but their primary caregiver as well. And so if we don't have that accurate diagnosis, there are quite a few symptoms that go undetected and untreated. As I mentioned, people with LBD have significant medication sensitivities. And by getting that differential diagnosis early, both the physician and the family caregiver can be very alert to watching for medication side effects and to make sure that they don't inadvertently get treated with medications that fall in the class of the traditional antipsychotics. And I'll talk more about that a little bit later. And last but not least, educating the family caregiver about what the disease is, what the symptoms are, how it progresses, how they can adapt and cope, provides benefits not just to them but also to the person they're caring for. And so we have lots of reason to strive for early diagnosis here. And I will say this because my father had LBD. One of the things that I think most families really struggle with is making sure that their loved ones are protected from medications that may be harmful to them. So both proactively treating them and protecting them from these medications are both top reasons to get this diagnosis early. But what we've learned is it is very hard to do that. We did a survey of nearly 1,000 LBD caregivers back in 2010, and what we learned at the time was that 2/3 of them required at least 3 doctors before they got to an LBD diagnosis. And half of those diagnoses took a year or more. So some families are seeing 5, 6, 10 doctors over the course of multiple years before they ultimately get a diagnosis. And in that amount of time, their loved one is not getting comprehensive clinical care. They don't understand the course that the disease course. They don't understand the challenges that they're experiencing. You can't put all of this into context without having that differential diagnosis. We also asked them about who was making the diagnoses, and what we learned were that almost 2/3 of these were being made by specialists. Fewer than 10% were being made at the primary care level. And so our message to physicians is that if you sense that this is an atypical dementia, please make that referral right away to a neurologist. Getting neuropsych exams is a very helpful part of the diagnostic process to assess which of the cognitive domains are impaired compared to Alzheimer's disease. The last thing that we learned was that more than 3/4 of those caregivers reported that their loved one was diagnosed with something else before they were diagnosed with LBD, and the number one misdiagnosis was Alzheimer's disease. But some of them were diagnosed with Parkinson's disease, and many of those diagnoses, rightly so, are correct because their loved one may have presented with prominent motor symptoms first. But the third category were psychiatric disorders, so late life psychosis. So it's something for us to look at across a number of different specialty areas to make sure that there's quite a bit of physician familiarity with the disease. With all the different symptoms that LBD has, if patients aren't being screened across all of those different areas, this diagnosis is easy to miss. So the symptom presentation can vary from person to person. One person may present with REM sleep behavior disorder and dementia, where the next person may present with visual hallucinations and maybe some mild Parkinsonism and mild cognitive impairment that's getting worse. That's going to be a very different clinical profile. So again, physicians don't have the ability to view this as a single presentation. It really varies widely. Symptom reporting by the family is quite different because, for example, who would think to tell their neurologist they're experiencing constipation? That is not something that we necessarily think goes with dementia. We might tell our primary care doc that, but we may not tell our neurologist. And so making sure that the full list of symptoms is explored is really important. And patients don't often disclose or have insight to some of the symptoms that they have. And having an informant with them, a family caregiver, for example, or family member would be really, really helpful. People with RBD may not recognize that they are moving about in their sleep, but their spouse might. The person with LBD may not feel comfortable admitting that they're having hallucinations. Or have some insight into the degree of the cognitive impairment that they are experiencing, where a family member can say, no, they're considerably off their baseline, something is really wrong. The fluctuations themselves make it very difficult because people will go into the physician's office, and we hear this all the time. I took my dad into the doctor, and dad was on top of his game, charming, friendly, bright-eyed, and the doctor did not see what I was telling him. But at home, in their normal environment, the person may be more confused. They may be demonstrating symptoms that come and go, like a hallucination. The doctor may not ever see that. So, it's really important that we have a partner as part of the diagnostic process. Certainly, at the primary care level, as I mentioned, so many symptoms involved. This may not be a disorder that is easy to diagnose at the primary care level simply because of its complexity. And the time allowed for an individual session or appointment may require that they come back several times before the doctor really gets the full clinical picture. without getting a referral to a specialist and without the neuropsych testing, the likelihood of this disorder being diagnosed reduces considerably. And last but not least, we don't yet have a biomarker that is able to definitively diagnose LBD during life. It would be really, really helpful to see the development of something that can detect the presence of alpha-synuclein at different levels in the brain. Researchers are working very, very hard at that. Unfortunately, we just don't have that available yet. So our goal with treatment is to improve the quality of life for both the person with LBD and their primary caregiver. Unfortunately, though, there are no treatments that will halt the progression of the disease, and so really managing the symptoms to the best of our ability is what our goal of treatment is. Certainly, medications, like I said earlier, donepezil, medications in that same class are used to manage the cognitive symptoms and can help with the behavioral changes. The sleep disorders should all be screened for and treated because without those being well managed, cognitive performance is always going to be subpar. So it is really important that they be proactively treated. Parkinsonism can be managed to a certain degree with the carbidopa-levodopa, but as I'll talk about in a minute, it's kind of a catch-22 in treating the Parkinsonism. And certainly the use of antidepressants is very common in LBD, and as needed, cautious use of the atypical antipsychotics, and I'll talk about that shortly. But more so than just the medications, there's also a role for occupational therapy, physical therapy, speech therapy. Just like people with Parkinson's disease, the voice can become soft or hoarse. They may experience, as the disease progresses, significant problems with swallowing. So getting speech therapy on board is helpful. And educating that caregiver and providing them support is just as important as treating the person who has the disease. And I put that in here as treatment so that you understand that you look at both the patient and the caregiver as a dyad. They are part and parcel of the treatment process. And I'll talk a little bit more about why that's important. But let's look at the medication sensitivities before we go further. As I said, antipsychotics are used to treat the hallucinations, which are common in LBD. However, we have to be careful because not only can they increase confusion, they can worsen Parkinsonism. And in rare occurrences, a person with LBD can develop something called neuroleptic malignant syndrome. You know, the advice from specialists is start at a low dose, progress very slowly up until you reach a therapeutic dose, and for side effects. If possible, avoid the use of the antipsychotics. Not every hallucination is a scary one. And so if the person is distracted by them but not distressed by them, or they're not changing their behavior in a way that is causing significant safety risks, or it's not making them so resistant to care that, you know, that they're, again, not being cared for properly, if those things aren't happening, you may be able to go without treating those hallucinations. Other medications that are known to have some side effect risk are the treatments for Parkinsonism that can worsen visual hallucinations. So you can see there's a catch-22 there. So, you know, if the Parkinsonism is mild, the advice is to leave it alone, not treat it. Only when it really becomes significant and interferes with function is when we really should be looking at what treatment is necessary. And even the cholinesterase inhibitors have some issues. They are known to have some GI side effects. More people than not adjust and tolerate that over time. But for some people, it can make them even a little more confused or drowsy. So, treatment of this disorder is not simple, but it can be done, and the more comprehensive the treatment approach you take, the better it is for the family in general. The treatment of psychosis or hallucinations and anxiety doesn't start with medications. And it's really, really important that this message get out to long-term care communities, emergency responders, hospital-based physicians, because there are a lot of things that can be done before medications get involved, and that can be, things that we can do to make things better before even a healthcare professional is involved. So first and foremost, we have to look to see what is causing the hallucinations. It may not be the disease. It may be an infection. It may be pain. They may be experiencing something completely unrelated. So let's rule out something as simple as a urinary tract infection. Take a look at their medications. Have a physician review, are there medications that should be reduced or even stopped? Look at the environment and see what's going on. Are there behavioral changes because there's a communication problem between the family caregiver or a professional caregiver and the person with LBD? Do mirrors or the television create misperceptions or delusions? And can we simply change that so that we minimize the delusions without going the route of medication? Certainly looking at how we can do things such as providing a response to a person's anxieties and concerns verbally and emotionally, providing them support in a way that we're not denying their reality, which may not be based in truth, but it is still their reality. So how can we provide comfort and help them get a sense that everything really will be okay? Certainly the use of the cholinesterase inhibitors and antidepressants are encouraged before we go the route of antipsychotics, but if that is still not effective enough, again, as I said, start at a low dose and slowly titrate up. Prognosis for the disease varies considerably based on a number of things. So like Alzheimer's disease, it can be as short as 2 years or as long as 20. But what really affects prognosis is the person's general wellness, how many other medical conditions do they have, and is their clinical care appropriate? There's a difficult reality that even a single dose of haloperidol can have a negative effect on a person's disease trajectory. Multiple doses can truly be debilitating. We've heard very difficult stories of families whose loved ones went into the hospital, were given repeat doses of haloperidol, became unable to walk, unable to communicate, and their life was never the same again, simply because somebody didn't know that either the disease had the medication sensitivities or the individual had not yet been diagnosed. And so obviously I can't underscore enough the importance of physician education and driving early diagnosis in this disease. On the whole, the life expectancy after diagnosis is about 5 to 7 years. That most people will fall in that general age range, that general life expectancy range. But as I said, a small percentage will have a very aggressive disease course. And some, for example, my father had a fairly slow disease progression. We still don't understand why some of these vary so widely, so there's more work to be done there. When we talk about the disease from a caregiver perspective, as you saw, we have such a wide span of symptoms here that the caregiving load is heavier simply because we're dealing with motor changes, behavioral changes, cognitive changes early in the course of the disorder, and a lot of unpredictability and disrupted sleep. So it is simply just by the nature of the disease, there's a lot of work for the caregiver to do. The fluctuations, like I said, make life unpredictable, and people with LBD have a loss of their ADLs sooner than people with Alzheimer's disease. And often that's driven by the motor symptoms and the autonomic symptoms. And studies are starting to show that people with the caregivers of those with LBD are facing increased stressors than people with Alzheimer's disease. And so it's really important that we provide the caregivers as much support as we can from the outset We certainly encourage them to become very knowledgeable about the disease. Sometimes they are the first line of defense against the traditional antipsychotics. We find it really important for them to join a community, whether it's a local support group or an online community, but that they connect with others who are going through what they are going through. One of the questions we asked them when we did our caregiver survey was whether they felt that others around them understood what they were going through, and the answer, without a doubt, was no. This is not a disorder that your family and friends will know about, and so there's a significant amount of isolation that they experience because not only do they have to educate everybody about the disease, people who are not living with it day in and day out aren't seeing the magnitude of what the caregivers have to experience. And last but not least, we really encourage families to take action because there is nothing like feeling that you are making a bad situation better by taking action. That sense of empowerment and change that you know we are part of the solution is it just makes meaning out of this disorder. We're really excited to see a lot of momentum building, though, for this very, this disease that has really been kind of off the radar. Thankfully, the National Alzheimer's Plan is inclusive of LBD. We're really grateful to all of the organizations and individuals who have been working tirelessly to bring these issues up to the level of priority that it has now reached both at the state and federal level. So thank you all so much for the work that you're doing. I'm honored to serve on the Advisory Council for Alzheimer's Disease Research, Care, and Services at the national level. And so to have stakeholders now participating in that national strategy that represent the non-Alzheimer's dementias is a big step forward. And certainly the Alzheimer's Accountability Act has driven a significant growth in research funding, and we're now seeing that research funding reach the LBD research community. They've just announced awards to study LBD biomarkers, and again, those are tests that will help detect the presence or progression of the disease. So we are very encouraged about the work that is going on right now. I'm not going to read these now, but this is a list of research recommendations, and I've encouraged Victoria to share this presentation with others afterwards who are interested. Of the priorities that have been developed at the national level by the scientific community in collaboration with the National Institutes of Health, clinicians, lay caregivers, et cetera. This is the work that needs to be done for LBD to advance the diagnosis and treatment of it, and we're really, really excited to be part of that process. So at LBDA, we are the only national organization that's fully focused on Lewy body dementia. Our mission really is threefold. It's outreach to the families, it's education of the general public, healthcare professionals, families, et cetera, and it's advocating for and driving research forward. And we think that by combining all three of these, we really are having a significant impact, reducing the burden of the disease on families. We offer a number of ways for families to connect with each other, from our peer-to-peer support service called our Caregiver Link, to community groups, and both locally and virtually. We offer a variety of educational programming, such as our Lewy Body Dementia University events that are both, right now most of them are web-based, and those are recorded and available on YouTube. We've just released a brand new publication for the LBD community and its stakeholders on the state of the science. So I've put the URL down here if you're interested in reading it. We have a full version, and we have a short 2-page brief as well. As I mentioned early, this is October is LBD Awareness Month, and we have activities that engage the community, the LBD community, where they live, to join us and helping to shine a light on the disease. So I want to close my presentation here and open it up to see if we have any questions. So if you can, there is a chat window that you have on your screen, and I'm not sure that we have our technical issues resolved, so I may have to field those questions directly. So if we could ask everybody to look for their chat window and take a minute, and if you have a question, you can send it to me directly. You can see my name listed at the top of the participants. Or you can put it in the chat window for everyone, and I'll try to field those questions from there. So we'll give everybody a little bit of time to do that. And I think if we have to, we may need to just unmute the phone lines. We may need to have people actually speak their questions if the chat line doesn't work. All right, here's our first question. Have there been any cases of LBD in younger persons in their 30s or 40s? Yes, there have. Thank you very much for your question. Certainly the vast majority of diagnoses are 50 and older. However, I have a feeling that because this is a relatively young disease, from a research standpoint, certainly the disease has been around forever, but the knowledge of it among the healthcare profession is relatively young. It was only first defined in 1996, so it's only been 20 years. And so the research community has, the cases that they see are those who have, reached up to the highest level of clinical expertise, and they are largely 50 and older. But we are seeing individuals in their 40s regularly being diagnosed with it, people dying in their late 50s, not commonly, but it's definitely something that can happen. From what I understand, it's possible that that genetics may play a large role in people who are diagnosed at younger ages, and when I mean younger, I mean much younger, for example, under 30, that is very unusual, and that probably has more of a genetic basis. Do we have any other questions? Okay, I'm not seeing any other questions coming along. I am getting chat from our organizers. Any comments from our organizers before we wrap up? Oh, we have another question. Okay. We'll just wait while they type. Thank you all for your patience. We truly appreciate it. Okay, our next question. Can drug use lead to the onset of the disease? That's a really good question, and quite honestly, I have not heard anything that suggested that. I think, again, that looking at this disease from the cause standpoint, there's still a lot of work to be done to understand why these proteins are misfolding in the first place. So we certainly know that toxins can have a role in Parkinson's disease. So I do imagine, I think there's some common sense that says if that's the case, then at some point we will anticipate learning that there are some toxins that may help increase a person's risk. But those studies haven't been done. Certainly, from the military standpoint, Agent Orange is suspected to have a role in Parkinson's disease there, and so there have been benefits from the veterans, for veterans who are exposed in that era. So I think we just have a lot more work to do. All right, we have a comment from our organizers. I just want to confirm that you will be receiving a copy of the presentation. The presentation was recorded today, and so that will be shared as well, the link to where you can watch it again or pass it along to others. We really appreciate your time and attention during today's webinar, and we hope that you all found it useful. I will also give you my email address so that if you have other questions that you were not able to post, you can send it to me directly. I'm happy to correspond with anybody who has additional questions. Again, my name is Angela Taylor, and our email addresses are all formatted the same. So it's A for Angela, Taylor, T-A-Y-L-O-R, A Taylor at LBDA.org. So thank you so much, and I hope you all have a really great day.